Hello, good morning, good afternoon, good evening. My name is Claudia Cortes. I'm an infection disease specialist, an HIV specialist, and recently a COVID sort of specialist from the University of Chile. Thanks so much for this invitation. I want to walk through three clinical cases that I experienced myself in the hospital I work in Chile. So the first one he was admitted on March, at the beginning of March. He was a man of 47 years old, overweight with an hypertension and hypertriglyceridemia, both on treatment and very well treated. And his wife was positive 8 days before. And this was at the beginning of March, and those were our first cases in our country. He had 7 days of fatigue and headache before coming to our hospital, and just one episode of diarrhea. 3 days before he was admitted, he was with high fever, 39 degrees Celsius, myalgia and cough. And so he went to our emergency room, and he went before on the 16th. And there he have a negative PCR, no detective. The day of his admission, he have again a non-detective PCR, but he was with an obvious pneumonia in his x-ray, so he was admitted. And 3 days after he was admitted, he got a third PCR that was positive. So the physical exam, he had this resting dyspnea, he was cough, he had crackles in both lung bases, and he was 94 with 2 liters with a nasal cannula of oxygen. So you can see here his CT scan. So at that moment in March, we give him oxygen, of course, azithromycin, hydroxychloroquine, and acetaminophen for his fever. He went to a general guard. But 2 days later, he went on to respiratory distress. He was still feverish. He increased his oxygen requirements, so he moved him into the ICU. He was immediately connected to a non-invasive ventilator. We, at that moment, keep going with the azithromycin, with the hydroxychloroquine, and we start lopinavir and ritonavir. March, we thought it was something useful for him. A lot of studies were running at the time. There's no results, and we feel absolutely helpless and useless. So we prescribe what we thought was useful at that moment. We connect him a few hours later into an invasive ventilator because a non-invasive was not enough. We started prone ventilation. His PF ratio was 85, extremely bad. And after 24 hours being in ventilator, his PF was 65. He was not improving at all. And you can see here the progression of the infiltrates. He was not able to be moved to a new CT scan. So at that moment, we started methylprednisolone, tocilizumab. We stopped the lopinavir, ritonavir because it was not available a formulation to use it from this nasal gastric tube. We complete the 7 days of azithromycin. We keep going with the hydroxychloroquine until 14 days. At that moment, we start anticoagulation with enoxaparin in full dose and empiric ceftriaxone. He was not a healthy man. He was hypertensive, but he was very well treated, young with healthy family, healthy kids. And unfortunately, the 18 days after he was admitted, he died. So at that moment in March, we gave him a lot of medication that today, with the very good review that is done by the PAHO and the WHO, we know there is a lot of drugs. And here is just a fraction of the table one because it's so big. There's so many drugs that have been tested. And you can see here that black means no evidence or not estimable effect. And there is a lot of black. And there is just one green, that is glucocorticoids. And we know today's studies talk about dexamethasone. And now there is a red flag here, and we know that hydroxychloroquine or chloroquine can be harmful in mortality studies. These are all randomized controlled trials. There are not so many, as you can see, but hydroxychloroquine is one of the most studied drugs, and we know now that it's detrimental. But back in March, we didn't know. The second case, it's also a man, 38 years old. He's also overweight, like many of the men in my country. And he was transferred to our center from another small hospital after 3 days being admitted there. When he counseled in the first hospital, he has been for a week with high fever, dry cough, and increasing dyspnea before his third consult. When we received it in our hospital, we intubated immediately and we connected to mechanical ventilation. And he started with prone ventilation. We immediately started enoxaparin full dose. With him, we start convalescent plasma. This is in June, and methylprednisolone. And now if we go again back to the same table, convalescent plasma is gray. That means there is no evidence, pro or con, about the usefulness of convalescent plasma. But this is what we did in that moment in June. This is a very severe patient, very young. And you can see here the x-ray from the first day. We received it just before being intubated. And you can see the next day how the lung infiltrates are progressing. So on the third day or fourth day, you can see the cannulas here. He was connected to ECMO. So he is in mechanical ventilation plus ECMO with a severe, severe distress. So is ECMO an option for these patients with COVID-19? Yes, it is. We know that in the very first patients, the mortality of the patients who were connected in ECMO was extremely high. But then we learned that we have to select our patients very well. We have to do with the correct team that knows how to do it. And yes, ECMO, it's an option to try to keep alive some very, very ill patients. So first we have to apply the best conventional intensive care pre-ECMO. So ECMO is not on the first line of treatment in the ICU. Then we have to select patients that are really have a chance to survive and that their main injured tissue is just the lung, and probably most of them should not have any other condition besides the pneumonia or the lung compromise. And we have, of course, and this is very, very important because we're lacking of healthcare professionals everywhere in the world. So we need to reorganize our staff to have this cohort of ECMO. And of course, we have to contribute to the science for other future patients and see how is the best way to do ECMO. So this patient, this very young 40-something patient that entered in June, have all the possible complications that you are seen and that are described. You have a septic shock with staph epidermidis in 3 blood cultures, so he's vancomycin. Then in a bronchoalveolar lavage, we found Aspergillus fumigatus. Not clear if it was a real infection or not, but he assumed he was immunosuppressed at that time because of all these interventions. So we start voriconazole. You have this severe vein femoral lesion and that required several surgical treatment, and it was a big headache in the treatment of this patient. He had multiple transfusions because of this femoral lesion, and he had in that moment this hypovolemic shock. He went later with a ventilator-associated pneumonia with Serratia, so he received meropenem. We progressed after this long hospitalization with a cryptogenic organism pneumonia, so serosine high dose. Then he appears this persistent fever. And besides receiving all this blood transfusion and being immunosuppressed, so he have a positive CMV PCR, so he received ganciclovir. Then he, of course, have delirium, critical illness neuropathy, severe illness, and dysautonomy post-COVID-19. So many, many different complications in this patient. So here you can see his CT scan 1 month later he started, and you can see how damaged his lung tissues. So after 40 days in ECMO, without improvement at all of his pulmonary function, we start thinking about the possibility of put this patient in the list for transplant patient. Is this an option? Yes, it is. There are not so many. There are actually a handful of cases published in the literature in China, in Canada, in the United States, some in Europe, of course. And they give us some recommendation of what patients we need to consider. Of course, young patients, persons that really have some possibility to get a recovery if they have this replacement of their lung tissue, patients that don't have other organ damage, severe organ damage. So with this patient, we start this multidisciplinary management with a fundamental role of respiratory and physical therapies, a very, very slow rehabilitation, deal with his delirium, will deal with his neuropathy. And he actually never went into the list of transplant recipients because after 70 days, he was disconnected from the ECMO. And here you can see the patient. This is an authorized photograph of this patient. He was discharged almost 4 months after being admitted. And he continued with physical therapy after, and with supplementary oxygen after being discharged from the hospital. And here you can see an X-ray from a month later. He was dismissed, and then the CT scan that was just from last week, like almost 3 months later, and you can see these still fibrotic lungs. So the problem is that when you have a very severe case of COVID and you manage to survive, your patients may have some complication after, and they are going to need treatment after that. So pulmonary fibrosis is among one of the complications or the chronic complications that you can get from COVID. And the final and the third case is the oldest, also man, 72 years old, diabetic patient treated with metformin. He consulted after several days of dyspnea. The night before the admission, he had this intense chest pain and vomiting. That's why his family took him to the emergency room. He was with sinus tachycardia, and his SAT was 86 with room air. And here you can see, you don't need to be a specialist, but you can see here how it's moving. And of course, we have this positive SARS-CoV-2 positive PCR and this extensive bilateral pulmonary embolus with the right ventricular overload and a multilobar pneumonia, and intracavitary thromba that we all saw in the video with a very high pulmonary artery systolic pressure. We start with a high flow nasal cannula of oxygen. We start immediately thrombolizing with alteplase. Corticosteroids, we know this was at the end of June that dexamethasone was useful. And after the thrombolysis, he continued with anticoagulation with low molecular weight heparin and later changed to oral. And this 72-year-old gentleman was discharged almost without any complication after 12 days, going back to his family. So we can see here that inflammation, thrombosis, and destruction, this is one of the core problems that this virus generates in our patients. And the thrombosis can be in different territories, can be lung, can be heart, can be brain, and can be kidneys, you name it. So what's my taking home message from these two successful cases and one of our first cases that was one of our first deaths, is that this is a disease with multiple clinical manifestations. It's not just the lung. I know that you already know that, but I want to emphasize that it's not just the lung, and we have to take care about many other organs and put a lot of attention in many details. And the dynamic knowledge of this disease changes. Things change a lot from March to now to December. There are treatments that we used at the beginning that we know now they're harmful. We need to work in a teamwork. We need cardiologists, pulmonary, the infection disease, ICU specialists. Everybody have to be on board. We need to take care about polypharmacy and drug-drug interaction. Like every patient in the ICU, the interaction can be something that is manageable, and we need to take care into that. And these patients need post-discharge care, not only if they have physical therapy. If they're ICU patients, many of them will need mental or psychiatric support after being admitted with a severe pneumonia. So thank you very much for your attention.